Contributions Award from the Cognitive Neuroscience Society and the Bengt Winblad Lifetime Achievement Award from the Alzheimer's Association. He held the Robert Wartenberg Lectureship and the Houston Merit Lectureship of the American Academy of Neurology. His textbook, Principles of Behavioral and Cognitive Neurology, has been part of training programs in neurology, psychiatry, neuropsychology, and cognitive neuroscience. His current research focuses on the functional imaging of the neurocognitive networks, the factors that promote memory preservation in advanced age, and the treatment of dementias. His trainees in clinical, cognitive, and basic neuroscience lead major research programs in the United States and abroad. Please welcome Dr. Mesula, who will present the aphasic dementia of Alzheimer's disease.
Good morning, everyone. I can't tell you what a tremendous pleasure it is for a lecturer to be facing a real audience rather than a computer screen. So I thought I would make use of this opportunity to share with you some thoughts on language disturbances in Alzheimer's disease. So let me start with some basics. I think it is now universally acknowledged that the distribution and density of neurofibrillary tangles, which you see on the left side, on your left side, is much more closely linked to the severity and type of dementia than the distribution of neuritic plaques. And on the right side, you see a coronal section from one of my patients who died at the relatively early stages of Alzheimer's disease. And I examined this section with a special microscope that allowed me to put one red dot on top of each tangle. And I think you will see from where you're sitting that the density of tangles is much higher in these memory-related parts of the brain, such as the amygdala, entorhinal cortex, hippocampus. And this is why memory loss is such an initial and salient event in the course of typical Alzheimer's disease neuropathology, including in the early mild cognitive impairment stages. It's only later, as the disease progresses, that tangles spread, almost as if they are following axonal projection pathways, to other parts of the neocortex, including in the left hemisphere, language cortex. So this is why typical Alzheimer's disease, as it progresses, the patient, in addition to amnesia, also has language disturbance in the form of mostly an anomic aphasia. So language changes in typical Alzheimer's disease is dime a dozen. It's almost the rule. Today, I'm going to talk to you about a completely different type of language disturbance in Alzheimer's disease, one which becomes the initial cognitive problem and for years the major impediment to customary daily living activities. This syndrome belongs to the family of primary progressive aphasias. And the diagnosis of primary progressive aphasia is made when three criteria are met. First, there should be an acquired impairment of word finding, word comprehension, or sentence construction. This is the technical definition of an aphasia. Secondly, the language disorder should initially arise as the principal deficit without equivalent impairments of memory, behavior, or visual-spatial skills. That's what makes the aphasia primary. And thirdly, the etiology should be neurodegenerative, which makes it progressive. Last I looked at our brain bank, we had 118 autopsies of PPA patients, and in these, 42% had the pathology of Alzheimer's disease and 58% the pathology of frontotemporal lobar dementias. And the one common feature of all these entities that cause primary progressive aphasia is their predilection for the language-dominant left hemisphere. As you can see in this graph of map of cortical thinning, where 16 PPA patients with all kinds of pathologies were compared to their 27 controls, and the areas of significant peak thinning are shown in the form of these red and yellow patches. And one thing you can immediately see is the tremendous asymmetry which favors the left hemisphere and where it invades all parts of the language network, including Broca's area, Wernicke's area, the temporal lobe, and so on. Primary progressive aphasia comes in three major flavors: the agrammatic, the semantic, and the logopenic, each associated with a different area of peak atrophy, as shown again in these yellow and red patches. The agrammatic form is characterized by impaired grammar and fluency, the semantic form by impaired word comprehension, and the logopenic form with impaired repetition and naming. And each of these subtypes has a favorite underlying pathology: FTLD tau for the agrammatic, FTLD TDP of type C for the semantic, and Alzheimer's disease for logopenic. But as you look at these numbers, you can see that the relationships are not absolute. They are probabilistic. Nonetheless, until recently, because we didn't have enough autopsies on longitudinally followed patients, we had to make do with the assumption that the language disturbance in the PPA of Alzheimer's disease was of the logopenic type. Now we can do much better. This is a study based on 21 longitudinally studied patients who at autopsy had Alzheimer's disease neuropathology. And they were given standardized tests of grammar, word comprehension, naming, repetition, object recognition, sentence comprehension, and fluency. And each circle here shows the performance of an individual patient. Above the green line, it's normal performance. Between green and black, mild impairment. Between black and red, moderate impairment. Under the red, severe impairment. Now, you can see that performance is all over the place. So there is no specific pattern for the aphasia of Alzheimer's disease. Now, some of the patients clearly are logopenic, some are not, as shown by normal repetition, impairment of naming abnormalities, and severely abnormal grammar. So the bottom line, and by the way, this heterogeneity is not difficult to understand if you look at the atrophy sites of individual patients, as shown in these three patients, P26, P78, P100. The one common denominator is the peak atrophy in the temporal parietal junction in Wernicke's area, but the details differ explaining this heterogeneity. So the bottom line is that the logopenic PPA diagnosis at the clinic is not a perfect predictor of Alzheimer's pathology. Specificity is high, but sensitivity is low. However, this study has one practical implication. If you see a patient with PPA where the word comprehension score is anything more than mildly impaired, you can automatically rule out Alzheimer's disease as a pathology without any biomarkers. One of the most important features, as I mentioned, for making a PPA diagnosis is the preservation of episodic memory. Now, those of you who still remember what I said in my first slide will just wonder how it is possible for a pathology that has the greatest damage in memory-related medial temporal areas and where language disturbances are late could give rise to exactly opposite syndrome, where the language deficit is initial and the most salient feature. But first, let me show the evidence of preservation of episodic memory. This was a study done on 17 participants. Test-retest interval was 2.5 years, and test-retest change of this episodic memory test, a nonverbal test of memory, was 2.4% per year, which was not significant, whereas the test-retest change in the Boston naming test was 26% per year, which is highly significant. So clearly a specific progression of language while episodic memory remains relatively intact. The reason for this paradox is in the anatomy. Now, here we're looking at 4 panes from the same patient. This was a man who had an agrammatic aphasia in life and who was shown to have Alzheimer's disease as the primary pathology. The tissue was stained with thioflavin S, which provides a histofluorescent glow on top of tangles and plaques. The tangles are the small, bright circles, and the plaques are the large, fainter circles. Now, in the left upper plane, we're seeing the Wernicke's area on the left, which is part of language cortex, and you see the high density of lesions. Next to it, on the right side, same part of the brain stained in the same way in the right, which is not part of the language network. And you see this remarkable asymmetry of lesions favoring language areas. Now, this is odd because usually neocortical lesions in Alzheimer's disease tend to be symmetrical. But what's even more astounding is the fact that these lesions are more dense in neocortical language areas than in the hippocampus and entorhinal cortex, in a way that completely upends the Braak system of staging. So this is what is also called a hippocampal sparing pattern. Not all patients have this pattern, but in general, the group of PPA with Alzheimer's disease will have a higher ratio of neocortical to limbic tangles. This kind of atypical anatomy is also seen in the initial stages of the disease, as shown in this tau scan of patients with positive biomarkers for Alzheimer's disease and PPA. And what you can see here is, number one, the asymmetry, much more tangles in the left hemisphere than in the right, and also more in neocortex than in medial temporal areas. There are also interesting molecular features. As you know, apolipoprotein E4 is a major risk factor for typical Alzheimer's disease, but it is not a risk factor for the type of Alzheimer's disease that causes primary progressive aphasia. And then there are some TREM2 polymorphisms that increase the risk that Alzheimer's disease neuropathology will give rise to primary progressive aphasia. So I think we can conclude that the aphasic form of Alzheimer's disease is biologically a true variant of Alzheimer's disease, both because it has an atypical distribution of the lesions and also because it arises from a different molecular background with respect to disease factors. However, there are also some shared features of the aphasic form of Alzheimer's disease. First, amyloid deposits are just as widespread as in typical Alzheimer's disease. Secondly, there is a cholinergic denervation, as we have shown here, where the y-axis shows the length of cholinergic axons in millimeter per millimeter cube of cortical volume. And normal is in blue, and patients with PPA and Alzheimer's disease in red. And you can see a clear loss of cholinergic innervation which is mostly in language-related neocortical areas. And we found the cause of that by looking at the nucleus basalis, which is the source of these cholinergic innervation, and showing that there is a loss of neuron in PPA patients with Alzheimer's disease compared to control. This is important because usually aphasic patients tend to be excluded from clinical trials, and this shows that patients with PPA and Alzheimer's disease biomarkers should be included in both trials of cholinesterase inhibitors and the anti-amyloid agents. The single most important core feature of PPA, primary progressive aphasia in Alzheimer's disease, is the leftward asymmetry. And here is a specimen from such a patient. You can see that there is an almost cystic area of atrophy in Broca's area in the left side, no such atrophy in the pars opercularis Broca's area in the right hemisphere. So the asymmetry for the left is not just a hit-and-run phenomenon of the initial conditions, but it's a core feature that remains until the end of life. The biology of this asymmetry is unknown, but there is one observation which I think is relevant. We found that the frequency of learning disabilities, including PPA, is much higher in patients, in first-degree relatives of PPA patients than other dementias. So this curious finding became somewhat more interesting when we studied a very special family. The proband, which you see on top, came to see me with a very mild anomia, but it was progressive. I made the diagnosis of PPA. The atrophy was very, very mild. You see this red patch in the superior temporal gyrus. While I was taking the history, I found out that actually the patient had 7 siblings, which 6 of whom had a diagnosis of dyslexia. The family, the entire family, agreed to come and participate in our research. So we invited them to Chicago, and Dr. Weintraub tested them and confirmed the fact that 6 of them deserved a diagnosis of developmental dyslexia. However, they had all grown up and started successful careers, and they really had no major impairment when they were tested in daily life or professional life. So we did an atrophy map on the 7 siblings, and there was no atrophy at all compared to controls. But then Dr. Bonaktarpur took a seed which he put on the map of the 7 siblings, corresponding exactly in anatomy to the initial site of atrophy in the proband, and found that in the 7 siblings, this particular area had significantly decreased functional connectivity with other parts of the language network compared to controls. So based on this, we would like to speculate that primary progressive aphasia, at least in some families, not in all, represents the tardive manifestation of a genetic or developmental vulnerability of the language network, which in some family members gives rise to late acquisition of language, whereas in some members of the family it gets compensated by neuroplasticity, but then makes the language network a locus of least resistance for bearing the consequences of an independently arising neurodegenerative disease. So this is a speculation that we're currently following with large-scale genetic studies. So now that we have dissected the primary progressive aphasia of Alzheimer's disease at some length, what can we do about it? And I would like to divide the therapeutic considerations into 2 groups. Medical interventions, which are based on disease, not symptoms, and non-pharmacologic interventions, which are based on symptoms and not the underlying disease. Now, the medical interventions start with judicious use of biomarkers to understand whether the underlying disease is of the Alzheimer type or not. If it is Alzheimer's, then, as I mentioned, the patient becomes a good candidate for cholinesterase inhibitors or lecanemab or donanemab or some other similar medication that will be coming up in the future. Now, if not, we want to know if it's FTLD-tau or FTLD-TDP. At the present, we really have no specific way to make that distinction, with one exception. If on initial MR scan you see a focal atrophy of the anterior temporal lobe, you can be quite sure that the underlying pathology is going to be FTLD-TDP type C in 90% of cases, in other 10% Pick's disease, but definitely never Alzheimer's disease. Now, the reason why we want to know whether we have FTLD-tau or FTLD-TDP is to be able to channel the patient to the correct clinical trials. Non-pharmacologic interventions can be quite effective, especially speech therapy. It doesn't bring back the words, but it makes the patient better at communicative competence. Now, many of our patients come from out of state, so they go back home and they do not find expert speech therapists who know PPA. So this is why Dr. Rogalski started a program called Communication Bridge, which allows patients who are away from our center to receive online expert speech therapy focused on PPA. And then Dr. Morhart, also in our center, started an online program through Telesavvy, which gives educational information and help with effective communications to family members rather than patients themselves. Now, one of the most curious things about PPA is the fact that the right hemisphere would appear normal, shows no significant neurodegeneration, or at least not much, for up to 10 years. So why is the right hemisphere on strike? Why doesn't it take up the functions that the left hemisphere can't do? So this then has raised some attempts at therapy by doing direct current stimulation or transcranial magnetic stimulation in the right hemisphere. The results are interesting. Some of them, as in semantic PPA, are quite encouraging, but this is a work in progress that we need to follow carefully in the future. This is pretty much what I had to say today, and I hope I've been able to convince you that the primary progressive aphasia of Alzheimer's disease is a true entity that needs to be diagnosed quite strictly, and that this is very important for giving the patient and the family the appropriate information and also channeling the patient to the appropriate interventions. But on top of that, I hope I've also given at least the implication that the primary progressive aphasia syndrome provides really unique opportunities for understanding the neurobiology of selective vulnerability in neurodegenerative diseases, and also asking some pretty interesting questions about the biology of language. Thank you.
Please welcome back to the stage, Dr. Van de Fleur.
It is now my pleasure to introduce our next plenary speaker, Dr. Adesola Ogunniyi. Dr. Adesola Ogunniyi is Professor of Medicine at the College of Medicine, University of Ibadan, and consultant neurologist to the University College Hospital, Ibadan. He received his medical degree from the University of Ife, now Obafemi Awolowo University, and residency training at the University College Hospital Ibadan, specializing in neurology. He also had a neuroepidemiology fellowship at the National Institutes of Health, Bethesda, and his research focuses on the epidemiology of dementia. He served as a site principal investigator in the Indianapolis-Ibadan Dementia Research Study, the Identification of Dementia in Elderly Africans Study, and currently the African Dementia Consortium. He is a Fellow of the Nigerian Academy of Science. He is well published and reviews articles for many journals. Please welcome Dr. Adesola Oguniyi, who will present the epidemiology of dementia in Africa.
Thank you very much, and good afternoon, everybody. I'd like to start by thanking Alzheimer's Association for giving me this opportunity to present on epidemiology of dementia in Africa. I gather this is the first time this is featuring as a plenary in any of the meetings, and we're really grateful for this. And I'd like to thank Maria for this opportunity and all the people who made it possible. You agree with me that it's very difficult to follow Professor Mesula. 3 decades ago, I was one of those who used to subscribe heavily to his lectures in American Academy of Neurology. And so having to share the session with him is very humbling and quite surreal. So I'll get to the business of today, which is to talk about epidemiology of dementia in Africa. I have no disclosure, and I'm going to follow the 3 Ps. I'm going to describe the peculiarities of dementia, burden, the risk factors, talk about the problems, especially as the disease advances, and then the prospects, which will include the collaborations that are ongoing. We're all familiar with this diagram that came from the Alzheimer's Disease International about 8 years ago, which showed that the number of cases of dementia will increase to about 131 million in about 2050, and markedly so in low and middle-income countries. But 2 things are striking, which bother us in Africa, and that's that we expect 1 new case every 4 seconds, and that's quite a number. And second one is that the cost of care is enormous, 1.7 trillion by about 2030. So these are challenges for us in Africa. But a few years later, the global burden of disease provided new estimates of cases of dementia, and we show that Africa is in red from the map, world map that you can see. And there is a summary that the number of cases will increase by another 20 million from what was estimated by Alzheimer's Disease International, and that by 2050 you expect that there will be about 152.8 million people. And in sub-Saharan Africa, this increase will be largely because of population growth, unlike in Asia where it will be as a result of aging. And if we look at this map, you can see these horizontal charts showing that in Africa, the dark green color represents increase due to population growth, whereas in Europe, in Asia, slightly due to aging of the population. So why study dementia in Africa? We have demographic transition taking place. The panel on the right, the top one, shows figure from the US Census Bureau 2020, which shows that the growth of population aged 60 years and above by world region is going to be so high in Africa. We expect over 200% increase in cases compared with other regions of the world. And this is likely due to progressive increase in death rate and slight reduction in birth rate, which is higher than the death rate. And so the resultant is increase in population size. There are also other reasons which include changing lifestyles, and a few of the slides later will show this. We have opportunity for identifying novel environmental risk factors and possibility of investigating gene-environment interaction, which is very crucial. From this graph, you can see the growth of studies on epidemiology of dementia in Africa. In 2005, you could see just a few dots in Nigeria, in Egypt, and South Africa. By 2008, paper by Calaria, who is in the audience, you see that there are more figures from Africa, including genetic studies. And by 2015, most of Central Africa, going to South Africa, have been covered. The Northern Africa data appears to go with the Mediterranean region. And the last panel there is from Akiemi in 2021, showing that data had come from about 18 countries, and the figure is about the same, except that Ghana now will probably be painted in red because we now have incidence and prevalence studies from Ghana. There are notable studies from Africa. The first one is the Indianapolis-Ibadan study, which I was part of, which compared population in the diaspora with those in the native land, and the hypothesis is that if you can have different rates in these two populations, you can then tease out environmental and genetic factors. Second one is the 1066 data, which looked at data from low and middle-income countries who have 66% of the people with dementia and only 10% of resources, started by Martin Prince. And then we had some data from Egypt, and we have Epidemca, which was initiated by Malin Goshet, who is in the audience. And then we have the IDEA study, Ibadan, Tanzania, and connection with Newcastle. So these are the major studies that have provided data, which I'm going to use for prevalence. And then there are others that I'll present later when I talk about prospects. So we'll talk about the peculiarities and published facts about epidemiology of dementia in Africa, starting with the burden of disease of dementia in Africa. Now, data have come from about 24 studies. I'm not going to go over this, starting from the Ibadan study, which reported 2.29, which was perhaps the lowest, and then thereafter you can see studies. If you see at the lower bottom of the graph, of the slide, you see Tanzania repeated twice. So the same data, but analyzed using two different instruments. First one was analyzed using the DSM-4 criteria, and the second one used the 1066 algorithm, and you can see the difference in rates. It's just to make the point that instrument matters, and you can get varying results depending on what methodology you use. If you look at the next set of slides again, you see that from about 2017 and below, you find that there's been an increase in the prevalence that's been reported from Africa, which would suggest a paradigm shift. There was a paper by the Global Burden of Disease which showed that no meta-analysis was available from Africa before now, but now we have meta-analysis data and computational analysis. We have 4 studies that I've quoted there. There's one in South Africa by Van der Poel, there's Adeluye data, then Ojagbemi, and lastly, there's the one from Ghana by Lagvan using machine learning approach and artificial intelligence, and you can see the rates rising as high as 19.2 by computational analysis, which means that if you don't review patients yourself, you use machine only, you may get abnormally high rates. But the data by Ojagbemi is regarded as perhaps the standard for meta-analysis for Africa. There are usually or unusually high prevalence rates that have been reported, and I'm going to present 2 of them very quickly. The one was this study from South Africa by Trani, which gave a prevalence of 44.5%, which was quite high. And that was obtained using the Assessing Dementia instrument that was developed by Washington University, St. Louis. But when you use that and the Rudas, you'll get 6.2%. And if you use when you use readers alone, you get 6.2, but when you use both of them, you get 22%. Again, making the point that instrument matters. The second one is data from a geriatric center in Uganda, which gave a dementia prevalence of 46.2. Again, very high. Of course, we know this is a geriatric center, so carefully selected cases. And below that, we have data from hospital in Uganda and Zambia, reporting rates 27.2 and 28.1. When you have prevalence, you then want to compare with incidence and think about mortality. And the aggregate data is that the average incidence of dementia in Africa is about 2%, which appears to be slightly lower than 3.2 that reported in African Americans. In terms of mortality, you can see that the figure, the color for Africa is slightly different from the rest of the world because of higher mortality. And summary of that is that the overall mortality is about 2.28% for individuals with dementia. However, with regards to dementia subtypes, in Africa, Alzheimer's disease is still the highest, 57.2%, which is similar to the figures from Western countries. Vascular dementia seems to be higher in Africa by about 10%, 26.9%, compared with 15% in Western countries, and then you have the others. So we can then summarize in terms of burden that there's variable prevalence estimates between 2.3 and 46.2%, but these are mainly due to differences in study methodology. There is lower dementia incidence relative to other regions of the world, and mortality of dementia cases appears to be higher than age-matched control individuals. When you have dementia, then you have to think of 4 things. One is genetics underlying the process. You think of age-related decline. you also consider environmental factors and then think of comorbidities. We're all familiar with this graph on risk factors, global risk factors by Lancet Commission, which follow the life course. And I'm not going to go over that. Just shows that 40% of all dementias can be preventable if we apply the right techniques. But in Africa, what appears to be driving the thing is age. As you can see from this meta-analysis from Ojagbemi, about 96% of the risk factors could be explained by aging alone, which again agrees with what the global burden of disease had presented. With regards to risk factors from Africa, you can see that age is consistently shown to be significant in all the studies. Gender seems to favor female, being more affected than male in about 2/3 of the study. There are few studies, especially more recent ones, show that low education is a risk factor. And there are very few studies on ApoE. I'm going to talk a little bit about genetics in a while. So other risk factors include loneliness. I'm going to talk about vascular factors, BMI, low fiber diet, alcohol, stress, death of a patient, hearing impairment, and more recently, large households and poverty as important risk factors. Specifically looking at vascular risk factors, we've had some data from Ibadan, Nigeria. Hall reported that cholesterol levels in those without the E4 allele appear to show an increased trend with dementia risk. We also show that hypertension increases the risk, and the odds ratios are there. 52% increase in Ibadan, 72% increase in Congo, and then we have also peripheral arterial disease and mean arterial pressures as important vascular risk factors. There are a few other factors that are peculiar to Africa that I'm going to quickly cover. These include functional dependency, living alone, especially for men. That's from Adeloye Adukonu, who is also in the audience. Then weight. Individuals with dementia had a mean weight of 49.3 compared with 58.4 for age-matched controls in a study by the in-depth group. And on the panel on the right showed what we had done, looking at weight of individuals with dementia compared with normal individuals over a 10-year period, and we showed a progressive fall in weight by individuals who develop dementia for both gender. So weight loss could be an indicator of some disease, and we need to look out for that. Now, undernutrition is also featuring now, and the paper by Duruve showed that eating 1 meal a day per day was the sole factor associated with undernutrition in dementia cases, and very high odds risk, sevenfold increase. Then low fruit and vegetable consumption, which has been linked with stroke, is also a risk factor for dementia. And the latest paper by Trani in South Africa showed that multidimensional poverty, and those are the domains or the things that were looked at. So we can summarize the risk factors for dementia, for incident dementia, to be low education, low cognitive reserve, rural place of residence, hypertension, and a few others. Just quickly, I'll talk about diet. In our initial study in Indianapolis, we compared the diets of African Americans and Yoruba, and showed that Yoruba diet was predominantly carbohydrate, had very low fat, whereas in the African Americans, you had a lot of fat and low carbohydrate. And sorry, that's the slide I'm talking about. And I'll just take a phrase, a quote from a paper by Robert Friedland, that diets high in saturated fats and low in fiber produce microbial communities that enhance the production of inflammatory immune cells. What role this plays in the diet of the native Africans compared with those in diaspora, we need to investigate this in subsequent studies. And with regards to the fruit consumption, there is this paper by Onoja which shows that frequent vegetable consumption is inversely associated with hypertension, which you know is a risk factor for hypertension in Africans. Lastly, just to talk about stroke in Africans, just to review some of the papers that are available. The first two, Akiemi, who is in the audience, and from Ghana by Fred Safo, show that about 40 to about 50% of the individuals develop some cognitive problems. 8.4 will develop dementia, about 14 in Ghana. But more recent data by Ojagbemi on incident dementia over a year period gave a incidence rate of 4.52%. The last study from Tanzania was for acute cognitive impairment and acute stroke, cognitive impairment and acute stroke, and gave a frequency of 80.2%. And the risk factors were infarct volume. So I'm sure that represents delirium rather than real anything that we should really pay too much attention to. So lastly, social involvement and dementia. Again, we'll start with the Indiana